So I am going to present an article whose title is Evaluation of a Systems Analysis Improvement Approach to Optimize Prevention of Mother-to-Child Transmission of HIV using the Consolidated Framework for Implementation Research. And this is a study that was conducted by a team from the University of Washington, and I was privileged at one point to be trained in implementation science by the author of the article. So as a way of background, despite large investments in PMTCT, we know that we continue to see children turning positive, and putting that into our context, we see about 4,000 children who fall through the cracks of PMTCT. We also know that the PMTCT cascade is complex, crossing multiple biological phases for women and their babies, right from the first ANC through pregnancy, the postnatal period, to 18 months after delivery. And barriers to accessing PMTCT of HIV services occur at each of these steps, and that's why it's also complex. So some of the barriers that were identified in this article, but which we also identify with as a country, are human resource shortages, lack of service integration, lack of ongoing quality mentorship, poor patient-provider interactions, and the client-related barriers. Among the commonest are stigma, lack of transport to come to the facilities to get pickups of ARVs, disclosure issues that lead to GBV because this mother is continuously coming to the facility for drug refills. Specifically to option B+, we know that in option B+, we're starting mothers on ART, irrespective of their CD4 and their clinical status. So some mothers, a mother who walks into the facility and is happy she's pregnant, and you ambush her with this HIV test and it turns out positive, and you're telling her, I'm starting you on treatment, there are also challenges around there. And when an affirmative research was conducted in Mozambique, one of the study countries, they found out that 52% of the women return for drug pickups at 30%. So that means that you're losing almost half of your patients just within the early parts of the PMTCT cascade. And by 3 months down the road, you only have 38% of your clients coming back. Therefore, integrating all steps of PMTCT cascade into a holistic approach is a priority. And this team that conducted this study opted to use a systems analysis and improvement approach, in short form the SAIA, that was developed to address this challenge in those 3 countries. Briefly, talking about the SAIA trial, it used tools, methods, and approaches from the systems engineering to address the persistent implementation challenges in PMTCT. And the SAIA trial had 5 steps, including analyzing the PMTCT cascade, doing a process map, identifying issues with the workflow and modifying them, and then repeating the improvements over time. And I must say that the article we are reviewing today is a follow-on on the first article, on the first study that had all these 5 steps, as we'll be seeing. So the 3 tools that they used was the PMTCT cascade analysis tool, the process flow mapping, CQI, and the study was conducted in 36 facilities, 3 countries, stratified by country and patient volume at a ratio of 1:1, intervention and control arm. And they used an implementation science framework to understand the factors that are critical to the success of implementation to facilitate future scaling should any other country want to take up this SAIA approach. So briefly, talking about the consolidated framework for implementation research, it has 5 domains. And the first one looks at the intervention. We have what we call the outer setting, the inner setting, individuals involved, and the implementation process. And I will discuss this shortly. So this is what the consolidated framework of implementation research looks like. So you can see that at the very end, we have the intervention, And the intervention is divided into two, what we call the core components and then the adaptable periphery. And the core components are those things about the intervention that you must not change irrespective of the context or the country or the region where you're doing the study. And then the adaptable periphery are some of those things that you can play around with to put the study into your context. We also have the outer setting, which involves issues around, let's say if you're looking at a health facility, issues around the health facility, say community health workers, and any other things outside the facility that might affect your study. And then we have the inner setting. If you're looking at a study setting like this one where they were working at a health facility, the inner setting now here would be the health facility systems and structures that will affect the implementation of your study. We then have the individuals, in this case, who will be the health workers that you're going to work through to implement your study. And then we have the process. What are those things that you're going to do as you implement your study? So when you're using the CFIR, each intervention, each domain has different constructs under it. So when you're looking at the intervention, you're going to look at this intervention source. You look at the strength and quality of your intervention. What relative advantage does it bring on board? How adaptable is it? So for each of the domains, you have different constructs under those domains. If you're looking at the outer setting, like we said, you're looking at the patient needs, the peer pressure, what are the external policies and incentives outside your health facility that affect the implementation of your study. When you're looking at the inner setting, like I said, you're looking at, say, what is the culture of that health facility or wherever you're implementing your study. What is the implementation climate? How ready is that facility to take on this intervention? When we come to the individuals, you look at knowledge and beliefs. If you're doing an intervention through the health workers, what is the knowledge and what is the knowledge of these health workers and what is their belief about what you intend to do? You look at self-efficiency, the individual stage of change, individual identification with the organization. If they don't identify very well with the organization, they might be hesitant to anything that you introduce. And then lastly, when you're looking at the process, which is the fifth domain of the CFIR, you look at the planning. How are you going to engage the people that you're going to work with? How are you going to execute your intervention? And reflecting and evaluating of this that I've done. How is it achieving my objectives that I intended to do right from the beginning? So, and when do we use the CFIR approach? We can use it for formative research. You want to get information as a pre-implementation phase before you go ahead to implement your study. You can also use it post-implementation to evaluate what you have been doing. So I'll now go to the aims of this particular article that we are reviewing. And the first aim was to define the core intervention and the adaptable periphery components of the SAIA, which we saw in the intervention. So this aim is basically looking at understanding this SAIA approach. If I implement it in these different places where I'm planning to implement my study, what are those things that if I transfer this study, let's say to Uganda, what are those things that I must, as a rule, incorporate in my study? And then the periphery are, what are some of those things that I can modify in the context of Uganda in order to implement my study? Are we together? Good. So the second objective was to identify the contextual influences that explain the differences in the implementation success using the SAIA approach. So here it was looking at the different we were not able to see the different constructs under each of the domains, but it was now going into the details of those constructs under each domain to try and understand what are those things that if you put them in place, your implementation will be successful. Or if you don't put them in place, your implementation might fail. So that is what is the second aim is looking at. So moving on to the methods, it was a qualitative study. It was following a cluster randomized trial, like I mentioned. And during that time, during the first study that was conducted, they had 18 facilities in the intervention arm and 18 facilities in the control arm. And for this particular study that we are reviewing today, they did focus group discussions and key format interviews to do those two objectives that we've just discussed, and this was done in 6 out of 18 intervention sites. And the focus group discussions were also conducted for the in-country study teams, and they used the CFIR as a guide. So they used the domains and the constructs of CFIR to ask their target audience the questions that they needed to ask to evaluate the effectiveness of CFIR and the contextual issues. The setting, study setting, this study took place in 3 countries, Mozambique, Kenya and Cote d'Ivoire, and there was a mix of the high burdened, high level facilities and the low burdened facilities. And the study was done from February to December 2014, and they selected these different countries because they wanted to do their study in countries that have a difference in the health sector design, varying levels of resource investments, and also different levels of the HIV burden. Specifically for Mozambique, the adult prevalence is 15.5. The Ministry of Health provides most of the services, and they had a mixed approach of PMTCT, doing both option B plus for the high volume facilities and option B or option A for the low volume facilities. In Kenya, the prevalence was slightly lower, 8.6 in the Nairobi province and 11.1 in the coastal province. And here the high volume facilities, just like Mozambique, offered option B plus, while the lower level facilities offered option B or option A. And then for Cote d'Ivoire, the prevalence is much lower, like you can see. PMTCT provided mainly by public health facilities, unlike the other 2 countries where we also have a mix of the private, not-for-profit. And unlike the first 2 countries, Cote d'Ivoire was mainly using option B plus. So looking at the first aim, the procedure and analysis, this study, like I already mentioned, followed the SAIA end of study meeting that was conducted in 2014. Remember that the study ended in December 2014, but when they were doing like their end of study meeting, they now conducted this study that we are reviewing. And country teams participated in a 3-hour review of the core and adaptable intervention components. They used this, the CFIR to rank the SAIA activities, and the data sources they used were the field notes, the implementation assessment forms, and the different documents that they had been collecting the data on throughout the study period. They focused on the qualitative content of the intervention and the implementation process domains. So of all the 5 domains, their focus for this second study was mainly the first domain, which has the intervention, and the last domain, which was the implementation process. And they ranked using the CIFAR, as I will be showing you shortly. For this second aim, they looked at 2 health facilities per country, and each country they selected a high and low performing health facility. The performance was determined by the country study teams who had been going to these facilities over time, and they based the selection or the fidelity on how the facilities adhered to the way the study was supposed to be conducted. They did endline focus group discussions. They interviewed those different cadres that you're seeing there, and they used open-ended interview guides guided by the CIFAR domains and the constructs, and they also conducted some key informant interviews. They went through the usual process of coding, transcribing, coding, and then after they did that, 2 independent authors reviewed that material, and then they agreed on the ranking. If you have the article that was given, you will see how they scored that on page 6. And this is the rating scale that they used. M, if you may look at your papers on page 6, M represented the missing too much data. They all represented not distinguishing between high and low. +1, -1 was weakly distinguishing the low and high implementation performance, and +2 or -2, that meant that that particular construct under a domain, you remember we have a domain, and under the domain we have the different constructs that I showed. So they were now rating those constructs and saying, if I put this construct in place, how will it affect implementation? So if that construct showed that by putting that construct in place, the implementation will be very good, then that was strongly associated. Are we together at that point? If it was weakly associated, you can do without it, even if you had it or not, the study would still go on. It wouldn't affect the implementation that much. Then they gave it a +1 or -1, meaning that it was weakly distinguishing between low and high implementation performance. So moving on to the results, where we are looking at the core, what must you maintain if in the SAIA approach? Remember, you're using the CFIR to evaluate the SAIA. So they are now looking at what in the SAIA approach should you maintain as a must-do if you're to do that study, say in Uganda. And they found out that of the 3, the PMTCT cascade analysis that we talked about, the flow mapping, and the CQI, that of those 3, what you must do wherever you do the study, you must keep the flow mapping and the CQI. I will not go through the CQI because we commonly do it here, but the flow mapping meant that you look at how this patient walks into a facility and the detailed steps of what you're going to do for that patient, all the way from first ANC to 18 months, when you're making the final decision whether this patient is this infant is HIV positive or not, the 18 months rapid test. So that is the flow mapping. So according to this study, they found that the flow mapping and the CQI must be maintained. And the reason for maintaining the flow mapping was that it identifies system bottlenecks. You're able to identify the systems in the facility that are affecting implementation. It promotes team building because people are working together, and by doing that, you're encouraging sustainability. And it promotes better systems understanding and more accurate problem and identification. And for CQI, we do a lot of that here. Most of us, I assume, know a lot about CQI. It gives you a defined way of doing whatever you're doing, and it also mitigates the bottlenecks that you're identifying through the flow mapping. So for AIM1, the flow mapping and CQI are the core. And then looking at the implementation process for the core, for successful implementation, it was found out that you must do site supervision on a weekly basis for the first month and monthly check-ins thereafter. The PCATS, the PMTCT cascade analysis tool, was described as most effective in facilities that were high volume facilities. But in Côte d'Ivoire, they did score it as a core because they thought it was a waste of time. That's why it fell through and became the adaptable periphery. And in smaller facilities, like I've said, the PCAT was useful in in the other parts of the PMTCT cascade, but overall, it is the flow mapping and the CQI. Successful innovations were those that reinforced the MOH protocols. So they found out that whatever they did that was reinforcing what the Ministry of Health already has as standard affected implementation in a positive way. And things that required not too much writing were considered as factors that promote implementation. And for higher performing facilities, changes that targeted health service reorganization proved more effective. Remember, in the flow mapping, you're looking at systems, so you're able to identify where the system bottlenecks are and address them. And the presence of a study nurse ensured that ongoing prioritization of systems analysis is being done. At urban large sites with high prevalence, the SAIA implementation was reported to have improved external support, like working with the community health workers, investments in team building and sensitization that we already talked about. And from smaller facilities, it was found out that doing things like minor rehabilitation and infrastructure improvements improved participation. So moving to aim 2, that was looking at the constructs under the different domains to see which of those constructs are positively encouraging implementation. So those constructs were network and communication, having available resources like physical space, lab supplies, external change agents like study teams, execution where it calls for meetings and that continuous engagement and trainings, and those that were weekly, the ones that got +1 or -1, were having intervention source, relative advantage, complexity, and all those others. So in the discussions, 2 out of the 5 that were scored, these constructs here, the 5 that were strongly related with good performance, the study found out that 2 of them were inner setting related. The inner setting, remember, is the health facility issues. And 3 of those were related to the outer setting, where you have factors outside the health facility that could affect implementation. And resources were not strongly distinguishing whether you had resources or not, because all these studies were conducted in resource limited settings. And leadership was found to be very critical to successful implementation. The limitation is that they did focus groups in only 6 out of the 18 study sites because of the reasons they mentioned was the staffing and resources. So the conclusions were that future intervention studies should apply evidence-based implementation science frameworks like the CFIR to provide salient implementation data to support implementation in other settings, including PMTCT. Given the importance of inner setting and implementation process and the likely heightened importance of available resources, further applications of CFIR are needed in the low-income settings, because this was the very first study that was employing the CFIR in a low-resource limited setting. And just to critique the article a little bit as I come to an end, the content of the article was reflecting what the study team proposed to do. If you read the background, it was related to the study, and the article clearly stated its objectives and analysis. So the analysis and results were related to the objectives, including the conclusions. The study methods were clearly stipulated. You could read through and follow through and understand what the team wanted to do. There were a few weaknesses though. A detailed implementation process was not given in the article prior to the results section. When you read the results section, there are some things that they mentioned that they did, but they do not appear anywhere in the article before the results section. And when you look critically at the conclusions, you'll find that they are both related to the second objective. And so nothing really for the first objective. So our take-home points in our context that we can use the CFIR approach, to also do something similar for the different service areas that we have. And then core elements must be maintained. If we are to take on the SAIA approach, the process flow map and the CQI and the adaptable periphery can enable us to change the SAIA approach within our context. And lastly, I would like to acknowledge the following. Dr. Kenny Shea from the University of Washington. I used a few of his slides for the CFIR to demonstrate the CFIR, the Makerere IMS team for giving me this opportunity to present the fellowship that trained me in implementation science, and the SCP where I work for giving me time off to come and be part of this meeting. Thank you.